Hello everyone and welcome to this evening's Ask the Expert webinar. My name is Paula Hanford. For those of you who don't know me, I am the CEO of PSC Support and I'm joined in the background by our operations manager, Mark Chatterley. And we are absolutely delighted to be joined by my fellow countryman, Dr Andrew Yeoman tonight. And Dr Yeoman is a consultant hepatologist at the Gwent Liver Unit and a very knowledgeable PSC expert. He spoke recently at our Newport Information Day earlier this year, and if anybody was there, you'll know how knowledgeable Dr Yeoman is on PSC and PSC related conditions. Really appreciate your time tonight, Dr Yeoman, and thanks for joining us. And it's great to see so many of you with us tonight. I know some of you also joined us last night for the National Liver Offering Scheme draft recommendations meeting. So we've had a couple of busy evenings, but delighted that you have joined us tonight as well. I always really like these webinars where it's a free-for-all, a bit of a free-for-all, and anybody can ask any questions. And we always have a really good range of questions from somebody who's just been diagnosed to, people who've had the condition for 20 years or so and everything in between. Just remember that Dr. Yeoman cannot give individualized medical advice, but he'll do his best to answer all of the questions. And please put your questions in the question and answer section on your screen. You can also join in the chat if you would like to do that as well. So I've had a couple of questions emailed to me. So I'm going to start with one of those. And this is from somebody who's just been diagnosed. And they're a little bit unsure of terminology, I think, and doctors, and wondering what's the difference between a PSC specialist and a hepatologist.
Yeah, great kickoff question. So I'm delighted to be with you, Paula. Lovely to see you and Matt again, and welcome to everybody joining online. So it's a really uncertain time, isn't it, when you get given a diagnosis like this? And so I think it's trying to navigate that sort of care, isn't it? And trying to get the right information is so important. So if we look at hepatology is a subspecialty of gastroenterology. And it's a relatively modern specialty. It's probably only been around for about 20 or 30, maybe 40 years. And it's not as large a specialty as gastroenterology. And that means there's not a huge number of hepatologists across the whole of the UK. So that means some people's care for their PSC might be in hands of a gastroenterologist who does lots of other bowel condition work. Or it might be somebody who is a hepatologist who subspecializes in liver disease. Personally, I'm very fortunate. I spend almost all of my time looking after the diseases of the liver, and that gives me the option then of being able to really subspecialize in subspecialized areas of hepatology. And my major area of interest then is autoimmune liver disease. So that's PSC, PBC, and autoimmune hepatitis. But that's not the same for every doctor that every single person living with PSC in the UK will currently experience. So I think it's important to remember that to begin with. The degree of expertise and experience your doctor will have with these conditions will probably vary across the country. And we don't like that that's the case, but with the workforce as it is, it takes a long time to train specialists, and things are definitely improving. I've been a consultant for 15 years now, and things are definitely improving. There are far more liver specialists than there ever were before. And there are more and more people who are subspecializing in autoimmune diseases of the liver. So things are definitely improving for the better. But as a patient living with this condition, it can be frustrating if your local team perhaps hasn't got as much experience as either you would like or as would be optimal. That's not to say that people who are gastroenterologists who do lots of other things cannot be experts in PSC. It depends on what their own personal experience has been. But I think it's okay to ask people when you first meet them, when they're caring for a condition like this, is this something that they manage very often? Because sometimes if if you're not getting the answers you require, and we talked about this at the day in Newport, didn't we, Paula, about navigating healthcare systems and getting the most out of clinic appointments, is that sometimes it is okay to ask for another opinion for somebody who does have that information. So I'm not trying to be overly negative there, because there's lots of excellent doctors out there who can help manage your condition and can give you the information you require. But it's important to understand that context, that we are short in some parts of the country of appropriately trained specialists for rarer conditions like PSC. And so if you feel you're not getting that information, and actually this applies to any single patient in the NHS, you are entitled to ask for a second opinion if you don't feel you're getting the information you require and deserve. Then don't be afraid to ask for that. But it's helpful to get an understanding of how much your doctor knows about PSC if it's a condition that they see a lot of. Because if your PSC is very stable, even somebody who doesn't see a huge amount of it will still be able to look after it well. But if it gets more and more complicated, that's where we continue to involve super specialists. And even as myself, who's got a big interest in autoimmune liver diseases, I see a lot of it. I still seek out other people for opinions, because there's so many areas of uncertainty in this particular condition, and none of us have all the individual answers. And even collectively, we don't have the answers to everything. So it's important, about how experienced you are in these things, that there will be occasions where your doctor will need to ask other people for advice, because there are lots of areas of uncertainty within this condition. So I hope that gives you a bit of a flavour what hepatology is, that the fact that some doctors are very subspecialised within hepatology, but that some doctors who care for people living with PSC actually are more generalist gastroenterologists and might have a lot of experience through the years of practice that they've had. But it's kind of helpful to know that.
Great answer. There's another question from somebody who has been recently diagnosed with PSC and ulcerative colitis. The person has 2 blocked bile ducts. Is that early stages? Should they just concerned? Is that something to be majorly concerned about?
I think this is definitely one of those situations where we do need to talk in very generalities rather than specifically. But certainly, I would hope if you've been recently diagnosed and they've discovered blocked bile ducts, then the team there has a plan that is communicated to you about what the options are there to deal with that. So in most people who have a blocked bile duct, that usually means that they have jaundice, which is what we call that yellowing of the eyes and the skin, and can change the color of your urine and your feces. So if there is evidence of the bile not flowing adequately, and there's bile duct obstruction, then that's one of those situations where sometimes people need to have procedures to help unblock that. That's not always the case, because many people with PSC who have narrowings of their bile ducts, and it's important to remember that PSC is characterized by narrowing of the bile ducts of varying severities. But if your bile is flowing so poorly that you become jaundiced, then it's that group of people that are more likely to need procedures to try and help unblock that. So I would hope that is being addressed within that person's local team. And if not, it's okay to ask the question as, what is the plan for this blocked bile duct? The reason I say not everybody needs an unblocking procedure is that fluctuating liver tests is quite common in people with PSC, and people can even have transient jaundice, particularly if they have a bout of what we call cholangitis, which is infection of the bile duct tree. So the bile can be a little bit sluggish flowing through the liver, and then an infection comes along and really gunks it up temporarily. But sometimes treatment for infection can resolve that bout of jaundice, and the obstruction then doesn't seem to be quite so severe. So it's not inevitable that somebody with a rise in their bilirubin as mild jaundice automatically needs a procedure. But in general terms, it's those groups of people who have blocked bile ducts and jaundice are most likely to end up needing bile duct procedures to help relieve that. In terms of staging of PSC is kind of a bit more complicated than just what the bile ducts look like, because the bile ducts can look really narrowed on an MRI scan, and people can have no jaundice whatsoever, and the liver test can be completely normal. In fact, around 50% of people when they're first diagnosed with PSC are asymptomatic from the condition because it's picked up because of abnormal liver tests as part of their inflammatory bowel disease monitoring, or it's picked up on routine blood tests for other reasons. So not everybody who has even quite significant bile duct narrowing will have symptoms or clear-cut signs of that. So I think that's an important thing to remember as well. So in other words, the correlation between the scan findings and the stage of the condition is not that clear cut. And when we talk about staging for PSC, we don't really talk about classical stages, do we? If we look at all the information that we provide around it, there are different stages of liver damage that can occur with PSC. There are different stages of bile duct narrowing, and that is influenced by whether you're jaundiced or not just by the scans. But in essence, just having some blockage on a scan doesn't give us enough adequate information to say whether somebody is early stage or advanced stage PSC. It's a composite assessment of many different things, including the behavior, sometimes over time, and also what the liver blood tests are showing, what other assessments have been made to understand whether the liver in the background is damaged as well. So it's a composite assessment that is best discussed with your healthcare professional. So I appreciate that's pretty epic fence sitting, but I think hopefully this gives you that flavor of the fact that it's not simple to just, it's not adequate rather to make a stage assessment of one modality. The picture has to be looked at as a whole.
Holistically, yeah, of course. So somebody's got a question about their IBD team. I'm presuming that's okay to ask you as well. How often should my IBD team be in touch? Last seen in November 24 by liver consultant. So how long ago is that? Nearly, well, a good sort of 10 months now.
Yeah.
Had colonoscopy for UC in July this year, but surely that is separate from PSC, different teams. So how often should the IBD team be in touch?
Yeah, it's a good question actually. I don't think there's a set answer. I think it depends on how the service works, because in some centres you'll be looked after by a gastroenterologist who looks after your PSC and your IBD together. There's always an element of why do I need to see two different teams. I think if you have subspecialist teams, it's probably better to be under subspecialist teams, because those people, what that will mean is that probably the IBD specialist will probably be even more subspecialized in IBD, and the PSC person will be even more subspecialized in PSC. Again, the interval very much depends on your symptoms, because as we know with PSC, many people's colitis can be mild and it can be quiescent or quiet for very, very long periods of time. And in IBD, if your condition is quiet on the treatment you're on, you don't need to be seen that often for IBD alone. The most important thing with PSC, and you know what I'm going to say, Paula, is the most important thing if you have PSC and IBD is that you're having regular surveillance colonoscopies. So that means if you're having them done, the recommendation currently ideally is to be done annually. If you're having those done, whether the liver team or the IBD team have organized that, the IBD team and the liver team will almost certainly be communicating with one another by copying correspondence in. Then if your symptoms are quiet and you're having your surveillance, then some people don't need to be seen that often. And we always have to remember that some people travel large distances to their hospital sites. And do you need to travel large distances if things are well controlled? The key to that, though, is A, it is well controlled, and B, you feel, you know that it's well controlled and you know what to do if there are problems and there's been an agreement about that interval. So it's helpful to understand from your team when you leave a clinic appointment, always ask, when would you like to see me next, or when do I need to be seen next? And for some people, we even leave it at their discretion. If the surveillance is happening regularly and they're having regular reviews with either the liver team or the IBD team, we will often sort of say, well, look, I know you're seeing this person in 3 or 6 months, so we can catch up in 12 months, or we can keep it even more flexible than that again. And it is highly individualized depending on how bad the IBD is and how problematic the PSC is. So there's no set answer, but what's absolutely critical is if you have PSC and IBD is that you have an annual colonoscopy. But if your symptoms are not well controlled, that you know how to contact your teams so you can make sure you've got that link back into services. And a lot of IBD teams have nurse advice lines to be able to link in with if your symptoms are not well controlled. So make sure you avail yourself of those sorts of facilities.
Yeah, and the main point there is to ask when you have those
Yeah.
appointments, ask how you can get in touch. I've got some questions, quite a few questions actually on URSO.
Yeah.
Somebody's had it previously and now their consultant isn't giving it to them. So what's your view on URSO? That's my first question.
Yeah. So Urso is a drug that's not it's not licensed for PSC, but it has been used in the past. It's a drug. It's a synthetic form of a bile acid, so it's a chemical in the bile. And what it essentially does is it makes the bile a little bit less sticky. And so the attraction of using it in conditions like PSC is that if you can make the bile a little bit less sticky in a condition where the bile is being held up within the liver, then you might see an improvement in the bile flow, the liver blood tests, and the complications that we see with PSC. Now, in contrast to primary biliary cholangitis, or PBC, where URSO is very effective for a significant proportion of patients, we have never seen from clinical trials any significant improvements in PSC from the use of URSO. There's been lots of studies over the years. It was thought logical to use, but when you look at what we call hard endpoints, so a hard endpoint from a study is, does it really change the severity of your liver disease? Does it change the likelihood of you needing a liver transplant? Does it reduce your likelihood of developing cholangitis and bile duct growths and problems with your bowel? And the answer is, there's no good evidence that it does that. And so therefore, then it becomes an additional tablet burden sometimes when people are on lots of other medications. And sometimes people start on it for good reason. Sometimes it might look like originally like you might have PBC and they think, oh, we'll try you on the URSO. Or some people say, well, it's a pretty gentle drug. It doesn't have any major side effects. Should we try it and see if it improves your liver tests? And if it does, you can make an argument, should you carry on with it? There's no evidence it'll change the longer term nature of your condition. But if it makes your liver test look a bit better, we all kind of feel a little bit better about that. And there's no doubt that for some people, it does make the liver test look a little bit prettier. But I think the bottom line is that the struggle we've had with it is we haven't had any robust evidence that it changes any of the endpoints that really matter. So we use blood tests as a guide to whether it's going to improve the liver, but sometimes the liver blood test can be marginally better on a drug, but that doesn't mean to say it's changing the underlying disease behavior. And that's ultimately the holy grail for any chronic inflammatory condition is, can you prevent serious damage to the bile ducts? Can you prevent serious damage to the liver? Can you reduce the risk of cancer-associated complications? And at the moment, the answer is URSO doesn't do that, which is why it's entirely reasonable to then discontinue the drug.
I don't know if you heard that. I really apologize. My son was just coming in. Thank you for that. Somebody's asked, can URSO build up in the body if taken over a long time? And how would you know if that's happening? And is that a concern?
No, we don't think it builds up. It's a synthetic form of a naturally occurring bile acid. So it shouldn't build up in your body in that sense. So, I guess the question is, if you've got a full obstruction in your bile duct, is that going to create more toxicity? That's an interesting point, because I think there was one study. I said earlier that URSO is generally a very benign medication with few side effects. That's at the dose that we traditionally prescribe it at. There's one study in PSC where they thought, well, if low doses don't work, maybe we need to use higher doses, and maybe you just need more of this drug. And when they used almost double the dose that you use in conditions like PBC, they actually found that people on a really high dose of URSO actually had more complications. So I guess it's possible. We don't fully understand why that was the case. And it was a little bit of a surprise finding. But I guess it's not beyond the realms of possibility that if you have really significant PSC, and in this study, lots of people did have quite advanced PSC, is that might it be accumulating in the body in those people with the most advanced disease? I think for most people, that's unlikely to be the case. But if you've got chronic bile duct obstruction, might the drug then be toxic when it isn't in other ways? But for most people, it will be safe but not effective. But at high doses in people with quite significant PSC, there was some evidence that it could be harmful.
Thank you for that. Now, what is the difference between urso and non-urso? And we've seen, I think, well, I think you're going to talk about it now, hopefully. But when would you think non-urso might be available?
Yes, good question. So no urso is just a variation of urso. It's got a slightly different chemical composition, and those slightly different compositions can affect both its absorption by the body and the way it interacts in other metabolic pathways. And the theory being that it's more effective as a cholinergic, thinning the bile out and clearing the bile out of the liver. So there's been lots of interest in non-urso and lots of what we call cholestatic disease of the liver. So these diseases that affect bile flow, PSC being one of those, for very many years. And there's been interest in PBC as well, for example. But the increased enthusiasm around it comes back from some of the data presented at the European Association for the Study of the Liver in May this year, where data was presented from what we call a phase 3 trial. So that's done in human beings with PSC. And those phase 3 trials are usually in relatively small numbers of people. And what they did is they looked at blood tests and they looked at liver biopsies before and after treatment. And they looked at two things. They looked at whether the liver biopsy showed stability of scarring of the liver, and they looked at whether the non-urso led to more improvement in the liver tests. And the encouraging findings from this, albeit relatively small study, is that non-urso does seem to have a signal, a potential benefit in terms of it prevents more people from developing scar tissue over quite a short interval. I think that's an important point. The interval between the biopsies wasn't that long. And so you have to interpret that with caution then, because we don't know whether that response will be lost over time. But it did lead to an increased rate of people having stable liver scarring as a result of their PSC. And it did result in more people having improved liver blood tests. The other big problem, aside from the relatively short follow-up for this study, so liver scarring, for example, often occurs over very, very many years. So studies over a few years may not really pick up exactly what's going to happen for those people. And I think what we're really going to be looking for before these drugs get registered and licensed for their use is we need a little bit longer term hard endpoint data that it leads to an ongoing sustained improvement in those parameters. The second problem is that the alkaline phosphatase enzyme that we still rely on largely as the blood test that we rely on to see what's happening with the bile flow in the liver is not a particularly good biomarker. It's not a particularly accurate, sensitive or specific test for the PSC. So in other words, in PSC that is left untreated, the alkaline phosphatase, as I said earlier, can be completely normal with lots of bile duct damage. And I've seen it be really high in people with minimal bile duct damage on an MRI scan. So the correlation between the alkaline phosphatase enzyme and the severity of damage and complications isn't very robust. And so relying on that blood test alone isn't going to show us that things are definitely going to improve. And we've seen this a little bit with the urso story, a drug that we've been using for a heck of a lot longer in PSC. We've found that even though in a proportion of patients, it does improve the ALP test, that hasn't translated into improvements and long-term prevention. So it's an encouraging study, don't get me wrong. It's the first really encouraging randomized study we've had in PSC, and it really has energized the community to look at longer-term outcomes and in bigger subsets of people, and to look at other agents. And there might be some other secondary studies falling off that from things that are learned from that study. But at the moment, it's not enough to say that this therapy is definitely going to be efficacious, effective for PSC. So, I think the jury's out, so we watch the space in terms of when that might be available.
It's hopeful, though. It
is hopeful. Absolutely. I don't want to dissuade people from the fact that it is always hopeful. This is the first positive drug trial we've seen, but it hasn't kind of met that threshold of clinical meaningful change as of yet. Now, Sometimes that's because we haven't left it long enough to see that, or we haven't treated enough people. Because in some studies, you can see if the effect size is small, you need a much bigger study population to show that effect size. And in PSC, we are likely to see any intervention is going to probably have a relatively small effect size, at least over the next couple of years. But we're at the moment that the data isn't quite robust enough for us to be able to say this is prime time, but it is very encouraging.
Thanks very much. I'm going to stick with medications just
Yeah.
for now. What's your view on vancomycin?
Vancomycin, yes, I was pretty certain this would come up. So vancomycin is an antibiotic. It's not absorbed into the general circulation, so it just stays within the gut. It's probably most commonly used in the NHS to treat Clostridium difficile, so C. diff as people know it, which is an opportunistic bacterium that can cause quite nasty diarrhea in people who've had antibiotics, and it can be very effective for that. And there's been a lot of interest in vancomycin over a number of years, and the reason why vancomycin has been of interest in PSC is that, as best we understand it, PSC is an interaction between the gut and the liver in the vast majority of people, and something is happening within your gut microbiome, which is your gut bacteria, that is talking to your liver and talking to your immune system in complex ways that we don't fully understand. And in some people, that triggers an immune reaction to both the bowel and the liver. Now, what's interesting about vancomycin is that from the most recent studies, and there are several, there's some from the pediatric population, there's some from the adult population, is a very clear signal that vancomycin doesn't improve the liver side of things, but it can be very, very effective for the inflammatory bowel side of things. And it can be very effective in people who have failed quite powerful treatments for their inflammatory bowel disease. So I think the really interesting thing is that people given, if you give people a month of vancomycin, then their bowel symptoms will improve dramatically, but their liver tests won't do very much at all. You might see a marginal improvement, but it will tend to sort of flick back over time. So ultimately, at the moment, the main benefit for the use of vancomycin in PSC is to help manage colitis symptoms in people who've got concurrent inflammatory bowel disease. But it's certainly, what's again encouraging about that study is it sometimes these findings can open up other investigative avenues, because you go, okay, if we kind of know how vancomycin works, if we know what sort of bacteria vancomycin works in, can we then look at different chemical signals from these different bacteria? Can we look at, there's all these sort of fancy techniques, genomics, metabolomics, to look at how chemicals and how genes interact with our environment. Sometimes you can find other avenues for further scientific inquiry to try and get to a closer understanding of the root cause of PSC and IBD. So very often that these positive studies can lead to further useful investigations and studies.
Very good. Really interesting, isn't it?
Is.
Do you have any data regarding PSC and the use of HRT during perimenopause and menopause? I'm wondering, this poster has said, if PSC could get worse for women during this time if they use HRT, or maybe even better.
Yeah. Short answer is no, we don't. I think there's probably lots of reasons for that. If you think of the so-called typical person with PSC, it would be, so the median age of diagnosis is 30 to 40-year-old male, but it can affect males much younger. 2/3 of people living with PSC are men, and so perimenopausal women with PSC are actually a relatively small subset of an already rare disease. So that would make study of this sort of thing really quite difficult. Now, that's not to say that you might not have more problems from your PSC when you're undergoing the menopause. I guess what's difficult to tease out with that is that the panoply of symptoms that menopause can trigger is enormous. You can get pruritus from the menopause, for example. You can get pruritus from PSC. So it's extremely difficult to try and tease out those different things. So it's a really interesting question. Will hormones have a role? Undoubtedly they will. But exactly what the interplay between hormones, sex hormones, and PSC isn't yet clearly understood. And I think it'll take quite a long time to try and get to that knowledge because of the relative rarity of women of perimenopausal age who have PSC. But I guess it's certainly possible, that you might see fluctuations in liver tests, you might see fluctuations in symptoms, but the key thing will be has been trying to understand the onset of those things. Were they there beforehand? Are they entirely new since HRT has been introduced, for example? Because certainly there's no doubt HRT and estrogen therapies can cause reactions within the liver. And I guess if you've got an existing liver condition, then is it exacerbating the PSC? Possibly not. It might just be the additional estrogen is just affecting the liver. But it might just be exacerbating your underlying symptoms because everything's a little bit more tickled up by a medication as well as PSC. So it's quite a complex sort of interplay between those two things. But unfortunately, we don't have any robust data.
Okay, thank you for that. Can you briefly explain what all the different liver function blood tests mean?
Yeah. So what liver blood tests mean in terms of what constitutes a liver blood test panel varies, depends on who you speak to. And so I'll just break it down by the sort of common ones that most laboratories will report. So they will report in order, usually on the sheet will be bilirubin, albumin, alkaline phosphatase, and ALT. Those are the commonest ones. Now, they're called liver function tests, but actually most of them are not liver function tests because some of them don't actually measure the function of the liver, although some of them do. Some of them can also be abnormal for non-liver reasons. And so they are better thought of as liver blood tests, but bearing in mind that there are non-liver conditions that can also cause abnormalities in any one of those four. We tend to sort of break down the blood test then into sort of two categories. Bilirubin and alkaline phosphatase are largely blood tests that tell us a lot about bile duct damage. And if your bile ducts are blocked, then the bilirubin and alkaline phosphatase will normally go up. Although in some young people with PSC, in the earlier stages, it's just the ALT that's elevated. But in general, bilirubin and ALP are generally thought to be related to biliary problems. And that's what PSC by and large is a biliary problem. The ALT is an enzyme that largely sits within the liver cells rather than the bile ducts. And so the ALT tends to go up when there is significant liver inflammation. And the reason it goes up in some people with PSC is in the very early stages of bile duct damage. What we tend to see on the blood tests is that early bile duct damage, before you see the evidence of damage on scans, is that early damage creates a bit of irritation to the liver cells who secrete this chemical. And sometimes the ALT can be elevated and the ALP and bilirubin can be normal in early stage PSC. So the ALT largely reflects what's happening within the liver cells themselves. Albumin is probably a little bit more of a liver function test in that it does tell us something of the liver's function. It's a protein that's synthesized by the liver, but it can go down for lots and lots and lots of different reasons. If you have an infection, you can lose, your albumin can go down. If you have kidney conditions, your albumin can go down. Any chronic inflammatory condition, including ulcerative colitis, will make your albumin go down. So even though if you only have a liver disease, albumin can be a helpful guide to what's happening within your liver, it's not specific enough to tell you on its own what is happening to the function of the liver. But we use it as part of that composite picture I talked about earlier. We look at a number of different features, clinical features, laboratory features, blood tests, scan results, etc., to give us an idea of how problematic something is. So those are the sort of common blood tests that form a liver blood test panel or liver function panel. Bilirubin and ALP largely relate to bile ducts, ALT to the liver cells themselves. There is crossover within PSC, and all those blood tests can become abnormal in non-liver conditions as well. So it's important to bear that in mind. If you see an abnormality in one, it doesn't automatically mean to say that your PSC has got a lot worse. But that's our job as doctors and healthcare professionals, is to interpret that for you and to let you know what that means. And if you're not certain, ask the question.
Yeah. And Mark, thank you for that. And Mark's just put a reminder in the chat that we do have an explainer on the blood tests on our website, and he's put a link to that if anybody would like to have a look at that. Just on the question of symptoms, somebody said that is a symptom of PSC painful, aching legs? And if so, is there any treatment?
So in short, yes, it can be. So PSC is a liver condition. It can be associated with inflammatory bowel disease. So you think, well, why on earth might my legs be painful and sore? So the reasons why are not directly related to what's happening within your liver, but if your liver is not excreting bile adequately, and certainly if you have quite advanced liver scarring, those things, and if you've been on steroids for inflammatory bowel disease, for example, all those things can lead to bone loss. So bile duct problems can lead to osteoporosis, as can steroid therapies. So if you have osteoporosis, or even its earlier form, osteopenia, thin bones rather than, frankly, osteoporotic bones, what can happen is you can develop, they're actually microfractures. So you can only see them on an electron microscope, but the bony structure gets disrupted. It gets thinner, it gets less stable, it's less rigid. And so what happens is you get these very microscopic fractures. And in some people, that can lead to chronic pain. So discomfort, soreness in the legs, around the bones can occur. So it's important, if you're having symptoms of that, to have your vitamin D levels checked. Vitamin D is vital for bone health. And people with bile duct disorders can have a low vitamin D level. Should have your vitamin D levels checked and supplemented if it is low. But in some people, the vitamin D level can still be okay, and there might still be some thinning of the bones that can be causing those symptoms. On the flip side, that's not to say that everybody with sore legs, if you have PSC, is due to that problem. I'm just saying that it's one of the possibilities. So there is a potentially a link, rather, between having PSC and having problems like that in your legs. But it's important for that to be reported so that can be looked at appropriately and investigated as necessary. And the biggest thing I would do would be to make sure somebody's got adequate calcium intake, check the vitamin D levels, and supplement the vitamin D if that is low as well.
Very good. So another question about symptoms. Somebody's suffering with multiple episodes of severe pain. And they're asking the question, why, if that, so they're already suffering with that, but their LFT levels are normal. So
yeah,
curious to know why.
Well, I think that there's several potential reasons for that. First is, say, and this isn't necessarily the most likely for this person, but it's always important in medicine and in life generally to not make too many assumptions. So I think when somebody has a relatively rare disease, there's a tendency for any other symptom that somebody presents with to be blamed on that rare disease. And sometimes it will be related, and it needs to be considered in the context of having PSC. But for example, you shouldn't ignore other symptoms that could suggest a new bowel problem or a new lung problem, for example, or a new joint problem. So it's really important to take every symptom on its merits and say, yes, could this be related to PSC? Could it be related to PSC, and could it be related to something else that's totally unrelated to the conditions you're known to have? Mm-hmm. So it's really important for open minds to be had around this. So pain is a relatively non-specific perception. So the body elicits or responds to pain in very limited ways. So if you think about when we get pain, it's often in quite broad bands, isn't it? It doesn't sort of point to the exact spot where the problem occurs, because our body perceives pain in a relatively crude way. So upper abdominal pain, yes, it could be related to cholangitis, for example. It can, some people with cholangitis, be the only symptom. But sometimes people just get fever, sometimes they just get itching. So yes, upper abdominal pain could certainly be cholangitis. Lower abdominal pain, though, is not going to be cholangitis. It's sort of physiologically, biologically implausible. So you have to then look for alternative causes even more readily if the pain is outside the territory of the liver and the bile duct system. So the location of the pain is important. But the other thing I would say then is that even if your pain is related to your PSC, the one thing I say to all the people I look after with PSC, when they have cholangitis, which usually if you've got pain, it's usually represented with cholangitis, is that the only thing typical about cholangitis in PSC is that it's atypical. It can be non-classical. You can have no pain. You might have fever and pain. Sometimes you'll have pain and no fever. Sometimes it'll be the other way around. So it can be so highly variable within the same person. And the liver blood tests I have seen in people with overt, obvious cholangitis, high temperatures, fevers and shivers, sickness, liver tests don't budge. Other people, minimal systemic symptoms, ALP, bilirubin go sky high.
Yeah.
It is so unutterably variable in PSC that I think you can have an episode of cholangitis with normal liver tests. It's not common, but it can happen. So I think that, summarize that really, the key things are pain, depending on where the pain is located. The health professional needs to be very specific at teasing out other possible causes and recognizing that PSC can behave in a myriad of varied ways.
Thank you. We've got less than 20 minutes and we've got quite a few questions still to go, but I think this is a great session actually. Somebody said they were diagnosed with PSC just 12 months ago and Crohn's disease 16 years ago.
Yeah.
She started to lose her hair and wonders if this could be connected.
Yeah. So again, not immediately and directly in the most obvious way. So if you think about classical links, if you have inflammatory bowel disease, you get a diarrhea, abdominal pain, rectal bleeding. Those are the classical direct consequences of having a bowel disease. PSC, itching, cholangitis, those are the direct consequences. But you can have indirect consequences, and those indirect consequences often result on the fact that if you have Crohn's disease and PSC, you have an autoimmune disorder, and other autoimmune disorders can co-occur. So about 40% of people with one autoimmune disorder will have a second, and about 10 to 20% of people will have a third. Alopecia can be an autoimmune disorder. Alopecia, though, can also be a consequence of body stress. And I don't mean feeling stressed because you've got an exam or job interview or something like that. I'm talking about physiological stress on your system. So alopecia can be a physiological response to body trauma and stress. And so if you have chronic conditions, that can also lead to hair loss. So it wouldn't be considered to be a direct consequence of that.
Yeah.
Other thing about another slightly tangential link is that there are some case reports of some people reported hair loss with URSO. So people have been on URSO. It has been reported. The link isn't really well established, but it certainly is something that we have seen reported from time to time. And other medications can sometimes cause hair loss. So not classically a symptom of PSC, but again, there are mechanisms or pathways or downstream consequences from having PSC that could feasibly contribute to alopecia, which is pretty traumatic, on top of all those other things to live with, isn't it?
Yeah, awful. Question about diet, and the questions on diet often pop up. I think people would love to take control and do something about their PSC, and diet they see as one way of doing that. But the question here is there any ongoing research in the area of ultra-processed food? Now, there's been a lot of talk of UPFs, ultra-processed foods, in the past few years. And they want to know, is there any research with ultra-processed foods and the link to IBD, PSC, as the diagnosis rates of IBD at least seems to have risen massively in the last 10 to 20 years?
Yeah, I think there's a number of different factors that probably explain the rise in IBD. Ultra-processed foods might be one of them, but I think probably more plausible in terms of at least the scientific inquiry and study is that I think one of the major reasons why autoimmune disorders are becoming more common is that we're living in more sterile environments. So autoimmunity is essentially a balance between, or not having an autoimmune condition, is a balance between having an immune system that addresses, identifies, and destroys foreign materials, so that's viruses, bacteria, etc., but doesn't actually react against our cells. When we are born, our body and immune system hasn't been exposed to any of this stuff before. And this is one of the rationales why breastfeeding is promoted and found to be helpful, because you can get some antibody transference through the placenta, but also breastfeeding can transfer antibodies from mother to baby that can build up some degree of immunity to things that baby's immune system hasn't yet been exposed to.
Yeah.
If you go through the first few years of your life not exposed to very much, don't pick up that thing that's been on the floor, sterilize everything, that is minimizing the exposure of the immune system to toxins, to bacteria, to viruses, and therefore the immune system is then potentially, if you have a genetic predisposition to those things, is potentially a little bit more reactivate or hyperactive rather against yourself, because it's not been tested, it's not been sort of, it's not been flooded in the early phases of life. And there is some interesting stuff around how many antibiotics you have in the early phases of life can change the balance of autoimmunity by moderating how your immune system responds to foreign material. So I think, there's lots of other things there. Ultra-processed foods may well have a part, particularly as they can affect the microbiome. But again, we haven't really fully, excuse the pun, bottomed out exactly what does that. But certainly ultra-processed foods do lead to a different proportion of certain types of unhealthy bacteria in the gut versus, people who are vegans, for example. It's interesting people, I don't know, people want to talk about fecal transplant, but fecal transplant seems to be de rigueur for lots of different inflammatory diseases. Yeah. When you're looking at fecal transplant and you're looking at using the optimal donor for a fecal transplant is a vegan. So vegan microbiome is like the holy grail. So that, a high meat diet isn't quite as good for your microbiome in your gut as a vegan diet is. And ultra-processed foods are probably worse again. But we haven't fully established the link. And the reason for that, I think, is that the number of different genes that are involved in any one person developing inflammatory bowel disease is huge. The number of interaction between different genes is enormous. The number of different genetic makeups in terms of microbiome is enormous. And the variations in people's diets are significant. Yeah. So it's a field with a huge area of promise, but there's so many competing causes or so many competing issues within those sorts of studies that it gets very, very hard to pin them down. But I certainly wouldn't be surprised if we see more and more linkage between ultra-processed foods and microbiome dysfunctions. And bear in mind what I said earlier, PSC is felt to be a disease whereby the gut-liver interaction is key. And this is why vancomycin might help, as an antibiotic, changing the nature of the gut bacteria. That's how vancomycin probably works in those with IBD and PSC. I think it will be an area of really strong focus for the future, but we haven't got that completely nailed down yet for all those complexities I've just laid out.
We're excited about the Fargo trial, yeah. Very excited to find out what the results of that is.
Yeah.
So we often have parents of children, young people with PSC on these forums, and you can understand the reason why. Somebody's asked, if PSC is diagnosed in childhood, does that mean there is a higher likelihood of needing a liver transplant at some point in life, since there are many years to live with the disease and it is progressive?
Yeah. So if we make an assumption from the get-go that the likelihood of severe PSC is evenly spread across the population, then the longer you live with a condition, you're more likely statistically to have a problem and you needing a transplant or an intervention. But that's not to say that it's an inevitable thing. These things are not binary. They're not will happen, won't happen. So I think there are people with PSC who will never need a liver transplant, will never develop serious enough liver damage. And we know that. And this is why it's important for that to be part of the clinical assessment when we're looking at what stage of somebody's PSC is. We need to look at how much scar tissue they have in their liver, not just how much bile duct damage they have, because that can be equally important in terms of when people come to you for the first time saying, I've read about these rates of liver transplant. Well, if you've not got any major liver damage and you haven't got major bile duct scarring on your, you might never get to that point. And that's a really important message. So whilst that can progress for some people, it's not inevitable that it's going to progress for everybody. So PSC diagnosed in childhood, though, it is slightly different condition in some ways. I think, in some centers it's called autoimmune sclerosing cholangitis. Very often, if you are diagnosed in the pediatric setting, people are often been on steroids or azathioprine or mycophenolate, which are immune suppressants that we would typically use for autoimmune hepatitis. And it can even look like autoimmune hepatitis in the pediatric population to begin with. So there's a bit more of an overlap between an autoimmune hepatitis-like picture and a sclerosing cholangitis-like picture. But we tend to find that over time, it tends to behave a bit more like the PSC that is diagnosed in adults, where you've got fixed bile duct damage. But as I say, it is a highly variable condition. It does behave differently for every single person. So I think you have to take it on its merits. You have to look at how severe the background liver damage is. You have to look at how severe the bile duct damage is on the MRI scans. You have to look at how many symptoms people have had with it, because there will be some people who will transition and will have loads of symptoms. And there'll be other people who've got relatively mild symptoms that are well controlled. And definitely there's a group of young people with PSC who are on immunosuppressant because their blood tests did dramatically improve when they were younger, but they sometimes lose that response as they get older, not inevitably. So it can be a slightly different disease, and it just warrants close watching, because you've got a very, very long life to live with that condition, with the potential for that to develop complications. But as I say, it is a highly variable condition, and it's important to look at all those different parameters of bile duct damage, liver damage, and the symptoms, and come into a conclusion about how likely that is to affect you now, but how likely it's going to cause you significant problems, needing things like liver transplant in the next 5 to 10, 15 years. And we do need to, the final thing on that, we do need to develop better prognostic tools, don't we? Our prognostic tools are very, very crude at the moment. And all we can say at the moment is that don't believe all the worst case studies that you read around PSC, because some of those are old and come from centres that see only the most severe cases of PSC. But at the same time, what we don't have to fill that gap at the moment is a study like, so in PBC, they've got some good risk scores to say if your bloods and your scans are this at a year, your risk of this development is X or Y. We don't have those, and that's partly because PSC is a more variable disease. It's less predictable in its behavior because it can affect both the liver and the bile ducts, and also it's a significantly rarer disease. So it's going to take us longer to accrue the long-term follow-up of enough people with PSC to be able to identify that.
Great, thank you. Another question from a parent. My daughter's almost 18. They're in the Netherlands actually, and she's been diagnosed with small duct PSC, which is quite rare, isn't it? And UC earlier this year through a liver biopsy. Are there next to FibroScan, are there other reliable tools to monitor progress in small duct? And how is your experience with MRCP Plus and ELF?
Yeah, so monitoring small duct PSC is really challenging because you've had to resort to doing a liver biopsy to diagnose that in the first place. So at the moment, the only really robust way of monitoring that is with repeat liver biopsy, but that's not something that we do in clinical practice. So the thing to remember, if you're quite young, you can have PSC on a biopsy that doesn't yet manifest as large bile duct changes. So we've certainly seen this in the adult population. Sometimes people present with abnormal liver tests. You think it could be PSC. You do an MRI scan, you do a liver biopsy, it doesn't show conclusive changes, and you keep an eye on them, not quite certain what the cause is. And then a year, 2 years, 3 years down the line, even though the liver tests are still the same level, or sometimes even better, then the bile duct damage appears. So it can initially look like a small duct PSC and evolve into large duct damage over time, or it can maintain. But actually, in terms of monitoring that, an MRI scan is a good way of monitoring that, because largely speaking, small duct PSC is a much more indolent condition than large duct PSC. It tends to cause far less complications in terms of the bile duct issues. Colorectal cancer risk is not higher in small duct PSC, for example. So what I would personally do if I saw somebody with a biopsy of small duct PSC is say to somebody, it could evolve into large duct. Not to find somebody say it definitely will. It could, it's possible. But to periodically do an MRI scan every couple of years just to see that hasn't evolved. Because again, your surveillance strategy is going to be very different if you have small duct PSC versus large duct PSC. If it's only in the small ducts, you don't need annual colonoscopies, for example. Whereas if it is in the large ducts, then you do. So it's an important distinction to make. So being aware that conditions can change their behavior over time, or they can manifest their behavior differently over time, and the importance of monitoring with intermittent MRCPs is what I would do rather than repeat liver biopsy. Coming back to FibroScan and ELF tests, so FibroScan is a non-invasive way of measuring the liver hardness as a surrogate for whether the liver has got scar tissue in it. ELF is a different way of doing that. We've got more experience, I think, of FibroScan and ELF tests, but both are helpful modalities at ruling out significant liver scarring. I guess you have to probably interpret ELF a little bit more cautiously in somebody who's got PSC and a really, really structured bile duct, because that in itself could elevate the ELF test readings. And we haven't got enough validated data in that to be able to truly extrapolate. But if you've got a low FibroScan or low ELF score, you can be very, very confident that things are nice and well controlled with no damage. Where it gets a little bit more muddy is if your FibroScan is high, because your FibroScan can go high during a bout of cholestasis. So if you've had a recent bout of jaundice, for example, and you FibroScan somebody at that time, it'll probably be quite high. But if you treat that and the jaundice gets better and repeat it, it might get better, because these are indirect measures of liver damage, looking at the hardness of the liver. Recognize that other things can put the hardness of the liver up. And if your bile ducts are damaged, that could potentially put your ELF test up. So the tests need to be interpreted in caution with that. But undoubtedly, these tests are being used more and more to monitor for liver damage rather than resorting to liver biopsy, which nobody's going to want to have a liver biopsy every couple of years. So I think these tests are definitely a big step forward, but bear in mind that they can sometimes be elevated for non-liver scarring reasons, and not to be too despondent automatically if your reading's suddenly gone higher, to bear in mind that there might be reasons like cholangitis or bile duct stricture, which might have temporarily put it up, and they might not be permanently elevated. So we have to interpret those tests in that context.
That's great. I mean, we've had a fantastic session. I've got loads of questions left, but I'm going to ask you.
I'm going to hard finish. We can go a few more if you want.
Yeah, I'm going to ask you sort of two related questions to finish off. And they're great questions, I think. What information provided by patients do you find most valuable during your appointments? What can patients, what do you need from patients? And what would you recommend they monitor, note, track themselves between appointments?
Yeah, really good questions, and these are things that we've addressed before at the patient conference, and
Yeah.
it's definitely something that needs evolution in terms of helping people. It's building that partnership, isn't it? Trying to get the right information. So in clinics, we have often very limited time, and clinics often rushed and they're often overrunning, and everybody's very fraught with that. And you've got your problems that absolutely need to be dealt with. So the single most important thing is to be as prepared as you possibly can be for the visit, in terms of knowing what medication you're currently taking. If you can remember, if you've had a change in your symptomatology, when did that start? So trying to have that as reasonably well documented. I mean, you don't need to keep like a 40-page journal, but certainly précis of when things started, when things changed, were there any obvious triggers? Because those sorts of that sort of preparation can be really helpful, so that we don't then have to spend time during the consultation teasing that information out, and then we can get on to the spend as much of the available time we have then to get into the, okay, what does that mean? How do we communicate that to you? And what are we going to do about it? So, except it's not always possible to be that. It can be difficult to remember sometimes, but try to be as organized with your medication and the change in symptomatology is the single thing that helps us, because then it frees up time for us to be able to get to that next step, which is what are we going to do about it, and how are we going to help you get better. So I think those are the things that we find, I think, most useful is that preparation for a clinic visit, and this, you've got everything to hand, rather than looking for this or the list of all your medications in the bottom of your bag and taking everything out and all those sorts of things, and you've lost 2 or 3 minutes sometimes, and and I think so little, it sounds really daft, but it can really make a huge difference to how we can utilize the time that we have together with patients most effectively.
And thank you so much for tonight. I'm just going to finish off by, it's not a question, but somebody's made a comment and they just wanted to say what a great session this is. I think Andrew explained things so well. I wish he was my consultant. Thank you, Andrew, they say. So that
Very welcome.
and somebody else has said, brilliant session. Such a shame we don't have hours and hours. Unfortunately, we don't, but we will try and repeat sessions like this throughout the year. We've got lots of hearts going up the screen. I don't know if you see that. You can see those, Andrew.
That's my daughter's logged in, I think.
Oh, right, okay. And lots of claps as well. So, yeah, just wanted to say thank you so much for coming along tonight and giving up your time. I think we really appreciate all of our speakers giving up their time free of charge in the evenings when they've got families and they've got other things that they would like to do as well. So, you know, I think that's absolutely fantastic.
Such a pleasure.
Thank you. We really appreciate your time tonight, and thanks for joining us. And it's great to see so many of you joining us today and asking us your fantastic questions as well. We've got the next session. It's a slightly different session actually, but one we think will work really well because we have lots of questions about this on our private Facebook group. And that is insurance, mortgages, and finance for people with PSC. So it is slightly different, but we think it's a really valuable topic. It's on the 16th of October. It's with somebody called Pam Brown from Pam Brown Mortgages, whose son has PSC. As I said, 16th of October at 7 p.m. But thanks ever so much for joining us, Dr. Yeoman, and to all of you who've joined us tonight. Thank you.